Broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. I'm Emily McFadden, Chief Executive Officer of HPV Global Action, and I'm pleased to serve as moderator for today's program. I would like to thank you all for joining us for today's continuing medical education webinar presented by HPV Global Action and the Consortium for Infectious Disease Control. Today's presentation is entitled Beyond Elimination of Cervical Cancer, a Strategy for Prevention of Head and Neck Cancer. We are very fortunate to have two international experts, Dr. Anthony Zaitoni and Dr. Cheryl Cable, join us to provide this very important presentation. We would also like to thank Merck Canada, whose support has enabled this webinar to be provided at no cost to participants. In today's webinar, Dr. Zaitoni and Dr. Cable will address the learning objectives that you can see on the screen. Sometimes it's a little bit slow to come up. The objectives are the clinical overview of head and neck cancer, the latest evidence of HPV vaccination, preventing head and neck cancers and RRP, review the burden of head and neck cancers, and understand the role of oral healthcare professionals in the prevention of head and neck cancers. George, I'm not sure I'm able to move the slides. I'll continue talking for now. Please note that the webinar is being recorded, and the recording as well as the PowerPoint slides will be made available following the webinar. They will be archived both on the CIDC's and HPV Global Action's websites, which you will see currently at the bottom of the slide. The recording, as well as the recording for other webinars and a number of other useful resources, can also be found on both sites. As well, you can join the Canadian HPV Network by completing a contact form online on the CIDC website. A few administrative notes. You can hear the audio via your computer speakers. All participants have joined the webinar in listen-only mode. If you would like to ask a question at any time during the webinar, you can type it in the question panel and click the send button. The questions that are submitted during the webinar will be saved, and all, or as many as we can, of the questions will be answered following the presentation, during the question and answer period at the end. If ever we are not able to answer all submitted questions, we will send them to Dr. Zaitoni and Dr. Cable, who will answer as much as possible in writing, and they will be posted on both the CIDC and HPV Global Action websites. Once again, you can see the websites at the bottom of the slide. So once again, the webinar will be recorded. The recording and the slides are both available on both websites. And finally, we hope that all participants will complete the webinar evaluation. On the current slide, you can see a link for a brief evaluation survey. If you have registered today and logged in with your own email address, you will be sent an email following the webinar with the survey link. Otherwise, you can also take note of the address. Today's first speaker is Dr. Zaitoni. Dr. Anthony Zaitoni graduated from Sherbrooke Medical School and a residency in otolaryngology, head and neck surgery at McGill University. After the residency, he obtained additional research training leading to a master's and then a fellowship in New York. He went to Zurich for further training in skull-based surgery. A strong believer in interdisciplinary care, he fostered the development of interdisciplinary clinics for head and neck cancers at the Royal Victoria Hospital and for skull-based tumors at the Montreal Neurological Hospital. He was medical director of the head and neck team, building the team into a strong supraregional center for head and neck cancer. More recently, he has served as a co-lead for the head and neck cancer site for the Rossi Cancer Network. Welcome, Dr. Zaitoni.
Thank you. Thank you for having me on this webinar. So I'm happy to present about oropharyngeal cancer and this new emerging pandemic, or epidemic at least, of HPV. Just seeing how the slide advancing works. Yeah, there we go. So I'll be talking about oropharynx cancer, which has become the leading HPV-related cancer in the world. So head and neck cancer affects many parts of the area in addition to the oropharynx, outside the oropharynx. It accounts for 6.5% of annual cancer cases worldwide. Most of them are in men. In Canada, we have about 5,000 to 6,000 new cases. And it's become now one of the top 10 cancers in men. I'll speak about these HPV-associated head and neck cancers, this emerging epidemic, the clinical manifestation and diagnosis, which is important for all of us as physicians, as nurses, as healthcare professionals, overview of the treatment options, and the burden that this cancer, this HPV-associated cancer, has both physically and psychologically for our patients. So as head and neck surgeons, we see cancers, squamous cell cancers of the mucosa of the upper aerodigestive tract, cancers of the parotid, the skin, thyroid cancers, sinonasal cancers, and tumors of the skull base. And today we'll be talking about the first one, squamous cell cancers of the upper aerodigestive tract. They're important because they're becoming more frequent. They're important because they have a disproportional effect on patients' abilities to function in society, to speak, to eat, and swallowing ability and one's appearance. So squamous cell cancers can affect any part of the upper aerodigestive tract, the oral cavity, the oropharynx, the larynx, and the nasopharynx. And today, because we're talking about HPV-associated cancers, we'll look specifically at the oropharynx. So HPV can be found in the oral cavity, in the larynx, and in some cancers associated with these, but they're not felt to be causative. The cause for oral cancer is still smoking and alcohol, same for larynx. And if HPV is found in the cells, it doesn't affect prognosis, it doesn't affect the treatment options. But for oropharynx sites, there it has a huge impact, so we'll see. So what are oropharynx? Where is the oropharynx? Well, the oropharynx begins where the oral cavity stops. So it affects the base of the tongue, the soft palate, the tonsils, and the back of the throat, the back of the pharynx. So we'll be talking a lot about oropharyngeal cancer, and I'll talk about interchangeably about base of tongue and tonsil cancers. They're both HPV related in many, many cases, in the majority of cases, and those are the main subsites. So the base of the tongue and the tonsils. So if we look at this diagram, the oropharynx is behind the oral cavity, not the tongue, but this area behind the pillars, the tonsillar fossa, where the tonsils are, and what we can't see really easily on this picture, but the base of the tongue. So head and neck cancer, traditionally, people, when I went to medical school, when I went to residency 10, 15 years ago, 20 years ago, 30 years ago, tobacco and alcohol, and it's still the leading causative agent for oral cavity, for larynx, for other subsites. But something new happened, something new we've realized in the last 10 years, and that HPV is related to this cancer. And in fact, when we talk about oropharyngeal cancer, so cancers of the tonsils at the base of tongue, we're almost talking about two different cancers. One is HPV related, and one is HPV negative or not related. They differ in their histology. The tumor cells look different. The demographics are different, so the age of the patient is different. So HPV positive cancers occur in younger patients, HPV negative in older patients. Both have a male preponderance. Often people who abuse alcohol and tobacco have a lower socioeconomic status, and that tends to be associated with HPV negative cancers. Tobacco, alcohol are causative agents. Not so much with HPV positive. So these are patients who come in, never smoked, never drank heavily. It seems to be associated with a number of partners, but not so much, not with alcohol, not with tobacco. Luckily, because of smoking cessation programs, the incidence of HPV positive cancers is decreasing, is falling. Whereas with HPV positive, as we'll talk about throughout the hour, the incidence is rising. One of my colleagues called this an emerging epidemic. Survival is much better. Patients are younger, they live longer, and the sequelae of our treatments bear more of a burden for many more years. HPV negative cancers have a much worse prognosis. They have a terrible, terrible prognosis, one of the worst in head and neck cancer. HPV positive cancers, much better prognosis. You know, with the kind of treatments we have in most of these patients, survival is 85% at 5 years, maybe better now. Again, this graph illustrates the difference in survival between HPV positive and HPV negative cancers. So this is time, 2, 4, 6 years, etc. You can see that the curve separating out very quickly. HPV positive cancers surviving, doing very well. HPV negative cancers, not so well, 30, 40% survival rates. So two different diseases, really, both affecting the oropharynx, this area behind the oral cavity and above the larynx. So it used to be, this webinar is very titled appropriately. We used to think of HPV-related associated cancers as something affecting women and affecting the cervix. Right now, and even for the last many years, the primary subsite of the body affected by HPV-associated disease is the oropharynx. So cervix is still important, but thanks to vaccination programs, thanks to prevention, less women are getting it. However, the oropharynx is becoming more and more frequent, both in males, primarily in males, as you can see from this pie chart, and to some degree in females. So trends in HPV-associated cancers. The cervix, actually over time, between 1995 and 2015, we see that the incidence is decreasing. Most of the other cancers are stable, some increasing slightly, and then oropharynx cancer in males increasing, wildly, basically. And this is something I see in my clinic, in my office, regularly. Again, so this graph shows HPV-associated cancers, and you can see again increasing, and it's projected to increase. So all of us, all of you, myself, our clinics, will all see more and more of these patients, more of them with cancers, more of them with the sequelae of treatment of these cancers. And this increases are happening in both men and women, certainly more dramatic in men, but in both sexes. So HPV is very common. It's the most common sexually transmitted disease. Most individuals in our society, at least 75%, probably more, will have at least one infection. It occurs via oral sex contact, and usually the infection will clear over time. Over 6 to 12 months, most people have cleared their infection. And that's it for the HPV infection. However, unfortunately, and in some cases, more often men than women, the HPV gets integrated into the DNA of the host. And it will stay there. And then many years later, decades later, the HPV will cause a transformation of some cells into cancerous cells. Why more frequent in men? People don't know exactly. Perhaps men have a higher number of partners, but there may be other factors associated with that, because the risk per partner is 3 or 4 times higher in men than it is in women. So it may be that the transmission of the virus is more effective when sex is performed on a man by a woman, and there may be immune differences between the genders. We don't know exactly, but this virus seems to cause these cancers in the oropharynx much more frequently in men than in women. As clinicians, as physicians, as dentists, as nurses, we're all going to be called on to see these patients and identify these tumors early. So we have already some from our training, this idea of what a head and neck cancer patient might might be like. Again, we often associate with smoking and drinking. And in these cases, they may have never smoked and don't drink heavily. So the presentation is different, the demographic is different. With HPV negative disease, most of the patients present with a sore in the mouth, a sore in the throat, a sore that doesn't go away over several weeks to months. HPV positive disease, often it's not a presentation of something in the mouth, but more of a neck node. They can have sores in the mouth, but it's less likely they can have a muffled voice, but it's less likely they can have a painful tonsil. But you have to think of your patients if they present with a neck node, a male in their 40s and 50s, a non-tender neck node, one that doesn't hurt, you would not need to think about cancer. And Michael Douglas was a well-known actor. He was very instrumental in making people aware of HPV cancer. Here he is at one of our fundraisers. So neck nodes, non-tender neck nodes that persist. Often a gentleman is shaving, looks in the mirror, sees this mass. It's important for all of us to recognize what it could be and to get him referred quickly. If you look inside the mouth, the tongue looks normal, but you can see here at the level of the oropharynx, a mass coming up from the base of tongue. Another bigger mass, harder to miss for sure, but this one would be easy to miss if one were not looking for it. More subtle mass at the level of the tonsil. You can see the pillar is being pushed from something underneath it. No ulceration. Another kind of dark red mass here. So sometimes you have to look for them to see them. You have to examine the neck. A few more. Small one on the palate, another one near the tonsil fossa. So they can vary in size. It's important to recognize them early. The treatment is very effective, especially for early stage disease. In medicine in general, in oncology, our treatment choices are surgery, radiation, and chemo. We always have to remember the psychosocial and psychological support that these patients will all need. Long time ago, in the 70s, maybe 80s, surgical treatment, again, most of these cases were HPV negative, treatment was big open surgery with radiation afterward. Surgery was effective, but the morbidity was very, very high. More recently, the last decade, the treatment that's been recommended for these cancers is high-dose radiation with chemotherapy. So the chemotherapy boosts the effect of the radiation. Super effective, extremely effective, cures 80%, 85% of these cases. The problem was, as the chemotherapy boosted the effects of the radiation, it also made the toxicity of the treatment very, very high. A third of these patients in some studies could not eat afterwards and had to be fed by a peg. They have dental problems, they have dry mouths. So these young 45, 50, 55-year-olds who had never smoked all of a sudden couldn't eat with the family. They would have to be peg fed. People have tried to continue to get really good cancer control rates, but have tried to look at other ways of dealing with these tumors. So the idea of using surgery has once again become popular. Not the surgery that was practiced in the 70s, but a more modern surgery, robotic surgery. And these transoral resections have been associated with excellent local control of the cancer. But fortunately, people were not permanently fed by a gastric tube, or very, very, very rarely, unlike with chemoradiation. So this has changed. So the pendulum has swung away, which was in surgery in the 1970s. Chemoradiation in the 90s now is more surgical treatments. Complications of any of these treatments are psychosocial, psychological, and physical. Psychological are very important in the head and neck population. Disfigurement associated with surgery of any of the head and neck cancers, loss of function related to speech, to eating, issues with anxiety and depression are particularly important in the head and neck population, including HPV positive oropharynx cancers. They have the highest rate of suicide ideation of any cancers in the body, some of the highest rates of anxiety and depression of any cancer patients for many sites. So there's also associated, because HPV is a sexually transmitted cancer, so issues of fear, of shame, of guilt, issues of infidelity in a couple, although the actual infection happened many decades before, and it's important to stress that to patients. So the complications are not only physical, but psychological. Depression, disfigurement, suicide risk, highest in any of the cancer sites anywhere in the body. So there's an important resources and an important need to be aware of this suicide risk. There are, of course, it's important to be aware so that we can tell patients what the resources are like, and identify them early and direct them quickly. So the need for counseling needs to be kept in mind. The burden has been well diagnosed. We know from other HPV sites, including the cervix, that there's a lot of fear, guilt, and depression associated, and it's even magnified more in the head and neck sphere. So these are the results from a social reaction to the diagnosis of HPV cancer in the cervix. We can extrapolate a lot of this to the head and neck cancer area, and remember that it's going to be even more intense in the head and neck. Complications are physical, contracture, lymphedema from chemoradiation, mucosal effects from the radiation. It will shut down production of saliva. They'll have dental problems that result. They have a very dry mouth, a lot of trouble swallowing, as I mentioned before. And in a large number of these patients won't be able to eat by mouth ever again. So chemoradiation is very effective, but leads to a lot of complications. Surgery as well, but less so. So we talked about the epidemiology and the differences between traditional head and neck cancers, older populations, smoking and drinking. Talk about the clinical manifestations, that this occurs in younger patients, more in men than in women, that non-tender neck nodes need to be identified early and investigated, and that there are treatment options. Chemoradiation is one, surgery is another, and that the burden of this disease is not only physical, but psychological. Thank you.
Thank you very much, Dr. Zeitouni, for this very informative presentation. We greatly appreciate it. I would now like to introduce you to our next speaker, Dr. Cheryl Cable. She is an associate professor at the University of Alberta in the Faculty of Medicine and Dentistry. She is a board-certified specialist in prosthodontics and fellow of the Royal College of Dentists of Canada with advanced training in maxillofacial prosthodontists. Dr. Cable serves as the lead for the Alberta Head and Neck Cancer Dental Leadership Team and is the founding president of the Canadian Association of Women Dentists. Welcome, Dr. Cable.
Thank you so much. I'd like to thank CIDC, HPV Global Action, and Merck Canada for facilitating this presentation. So let's look at a strategy for prevention of head and neck cancers. Next, please. So with disclosure, all of the contents and opinions are my own. I do not represent any commercial interests, and some of my recommendations may be off-label as an active practicing clinician in Canada. Consent's been received for all clinical images presented, and an honorarium has been received for this presentation. Next, please. So what do we know? What do we see? Next, please. The objections, okay, objection raised, sustained. Okay. Objectives of the discussion: latest evidence for HPV vaccination preventing head and neck cancers, understanding the role of oral healthcare professionals in this prevention, and what can we do today? A way to change our conversation. What if? Next, please. In a land so close to home, the problem is getting worse, so much worse. That was my attempt at Star Wars intro. Next, please. So we know the HPV attribution in head and neck cancers in Canada is increasing. Across Canada, there's a steady increase in the proportion of oropharyngeal cancers attributable to HPV. Next, please. So we've gone from 47.3% to 73.7% in the proportion of HPV. The epidemiology of oral HPV infection shows that this is the principal cause of an increase in the incidence of certain squamous cell carcinoma cancers in the head and neck. Next. So why vaccinate? Well, because it works. Next. So we know it works because when we look at the effect of oral HPV infection among young adults with vaccine, so with the HPV vaccination, it's associated with an estimated 88% reduction in prevalence of HPV 6, 11, 16, and 18 related oral infections among vaccinated young adults. That's men and women. When we look at just young men, it's 100% reduction. So these are speaking points that you can use when you're talking to patients, people who have questions for you. Why do we vaccinate? Because it works. So the vaccine load shows here. This is a really important article to talk to people about. Next, please. So why vaccinate? Because it's safe. Isn't that a timely conversation to have with people right now? They're like, well, I don't want that in. It's not tested. How do you know? The first phase 3 trials, clinical trials in females, was in 2002. So that's over 20 years ago. The quadrivalent vaccine was approved in Canada, plus 50 other countries in 2006. So if people are saying, why, is it safe? Well, it's been used in so many countries around the world, and we've got so many people who have been injected with this. Plus, I've had the vaccine, and I have had my children vaccinated. Those are really important conversations to have and statements. Next, please. So why vaccinate? Because the status quo is not good. It's the opposite of good. In fact, it's actually bad, really bad. And thanks to Dr. Zaytouni, you can see why this is so bad. Next, please. So the estimated age standardized rate of cervical cancer in 2020, so this is great. This is global Canada data from the World Health Organization. And this is really important for us to take a look at the world as a whole, because borders are not, they're not there physically. People travel. We know with people coming and going with immigration, we've got patients from all over the world. And this can't be a NIMBY, not in my backyard. You can't be so focused just on the data of your local community. People come and people go. So this is great. If you look at North America, you look at higher economic status countries, but what do we do to take care of our vulnerable populations? So those colors are the most important ones, because these are the people who need care. We have to look at how do we, in our community of communities, take care of the patients who have higher rates of cervical cancer, who are dying from something that is preventable. Next slide, please. I love this slide. This shows, again, from World Health Organization. Oh, no, this one's from Lancet. We're looking at women aged 30 to 49 years across the world, and distribution of the country's lifetime screening coverage. So the darker the green there, that's great. We've got anywhere between 90 to 100% coverage. We're following up. We're making sure we're checking on people. But what about those countries in red and orange and not being taken care of? So when a patient walks into your office, you can't assume that they have been stuck between the walls of your borders. You have to assume that these patients may be just completely fresh into Canada or into wherever you are, and you have to think about what their personal particular needs are and risk factors. Next, please. So let's look at the international scope. The World Health Organization says that because HPV infections are commonly acquired soon after sexual debut, they recommend use of prophylactic vaccines in early adolescence, and they're targeting especially young girls before the initiation of sexual activity. And again, that can range. So we're looking at ages 9 to 14-year-olds. In the schools, we're providing that in Canada about grade 5, grade 6 for prevention of cervical cancer. So this is expanded into boys, and we have to look at the school-based programs and the focus here. Now, what's happened through COVID? Well, even in Ontario, the vaccine uptake rate was down to 0.8% in the schools. We're missing people who have not had the opportunity to decide if that vaccine is right for them and to help those families facilitate injection if possible. Next slide, please. So let's look at understanding the role of oral healthcare professionals in the prevention of head and neck cancers. As Dr. Zaytouni said, there's a lot of long-term sequelae, complications of head and neck cancer treatment that we will see with patients, and the dental problems are completely devastating. And we'll look at that in a few minutes with a patient case. Next slide, please. So this is fantastic. I want you to think about the time that you spend with your patients doing an oropharyngeal or oral cancer screening. In Canada, on average, dental hygienists are examining their patients for 4.09 minutes. Most physicians are given 15, 30-minute maximum increments in when to see patients and dealing with their top 2 problems. So what we're trying to do is look at this as a standard of practice, and that's a regulatory definition on how we work. And that's an expectation of provision of care. So when a patient comes in and there is a billing code or a procedural code used on a head and neck exam, the expectation is 100% an oral cancer screening as part of that. So education, expectations, and support are really, really important in not just the clinicians, but in the insurance providers, and making sure they understand where time is and why this is so important to the long-term care and prevention of escalation of problems. Next slide, please. Now, let's look at dentists here. So dentists, where's the proportion of dentists who screen each anatomical structure? Well, realistically, it's more toward the front of the mouth. Dr. Zaytouni has told us that oropharyngeal cancer, HPV associated, is towards the back. And if you look at the bottom bar graph here, the trends and incidence of cancer by anatomical site, if you look where the clinicians are spending less time, is towards the back. So although 92.4% of dentists in Ontario believe that they're adequately trained to recognize early signs and symptoms of oral cancer, only 35.4% believe that they are adequately trained to obtain biopsy samples for suspected lesions. Now we need to get these patients quickly in to see a pathologist, oral pathologist who can do a biopsy, oral surgeon, or an ENT surgeon, head and neck cancer surgeon, somebody who can get there. So the diagnostic pathway, the treatment pathways have to be expedited. And that's something with the multidisciplinary approach, making sure that as a team, we are expediting care for patients, because things can accelerate quickly and quality of life can be dramatically affected. You know, less than 40% believe they're adequately trained to address relevant risk factors of these cancers as well. We need to make this conversation comfortable. One thing, you know, when we talk about communication, I'm trying really hard to focus with my patients looking at this is not necessarily a STD-focused virus, but this is a cancer-causing virus. And we'll explore some of that in a minute. Next slide, please. So we have to find the patients. We have to screen them using common language and making it something that's not embarrassing, not accusatory. We have to make sure that the patients know that this is part of a standardized healthcare provider expectation, that we're looking at the patients as a whole. You know, patients will be like, well, your medical history is not relevant outside of here. Medical history of a patient as a whole. Remember, oral healthcare is part of healthcare, and things that happen elsewhere in the body will affect what's happening in the mouth. We need to educate, and you have to have a personal risk assessment for every patient coming through. You have to make it personal. Once you make it personal, then people will listen to you. If it's not personal, then again, it's, you know, I'm 20 and I'm going to live forever. I'm not at risk. You know, I don't get hangovers. I'm fine. It's got to be personal. So we need to empower. You need to provide an opportunity, provide the prescription, provide the vaccine if you can, and you got to close the circuit. Once you identify the patient, you have to make sure that things are followed through. Next slide, please. So this is an infographic that I published with Dr. Ross Tsuyuki, who is a pharmacist. He's also the head of Epicor at the University of Alberta. And this is a very simple document, but it tells a lot. So what's the problem? There's a problem. There's a really big problem. What's the solution? You got to identify the patients. And this is for pharmacists. So when a patient comes into your pharmacy, you can talk to them. You're identifying an age range. You're looking at people who are immunocompromised. And you're going to collaborate with dental professionals. So you're going to have the dentist working with you as a pharmacist to identify, facilitate, and send the patient over with that prescription, or even just with questions. We've got lots of prescription writing pharmacists and vaccinating pharmacists. It really facilitates in closing that circuit. You need to inform the patients and explain, you know, just tools, like getting the facts and making sure that patients understand this is something you may not have all the questions or answers for at this time, but we're going to help you with that. And then you're going to mention prevention measures. And these are sometimes sensitive, but again, having a tool, something to pass across the counter for them to get further information, great websites really helps. And then vaccinate. And we have to make sure we're open to patients who are outside of the inclusion criteria, who may have higher risks. So we have to protect patients. So it may be potentially outside of scope, but we have to have the patient make the decision that's right for them. Next slide, please. So let's look at our case presentation. Next slide, please. And we started looking at this patient in one of my previous presentations here, but I want to give you some follow-up on where she is now. So diagnosed with squamous cell carcinoma on the left base of tongue. A lot of patients actually won't even know that they've got an HPV positive biopsy. Historically, surgeons were not aware or did not tell the patients, did not find it of value to the patients in their life journey. And it's of incredible value because HPV just doesn't stay within one individual. We know that over 80% of us will have had at least one active HPV infection in our life. So it's really important to be transparent with patients on that. So surgical treatment was completed, including removal of a salivary gland, and she went through radiation therapy. Next slide. So severe xerostomia, really dry mouth. When saliva changes, it's not just quantity, but it's also quality. And the remineralizing component of the saliva changes, so then the patient's at much higher risk for cavities. And cavities, these aren't dirty patients. These are patients who are really motivated, but it's a spiral down into destruction of what they've got. And so she's eating only on one side, has a cast partial upper denture, but she can't use that because now the tissue's friable. And that means it's really delicate, it's tearing, and she's now had a quality of life change. Oral health deteriorated, resulting in caries, large failing restorations. You know, there's heroics in here. Depressed, overwhelmed in how her life had changed, contemplating initiating a life protocol. Dr. Zaytouni told us about the 2 times increase in suicide risks. This is real. This is very significant. Next slide, please. So this is the panoramic radiograph. At the start, you'll see this section. There's a plate on her bottom left and on the mandible, and that shows where the surgeon sectioned the mandible to open her up in order to access base of tongue. Lots of restored teeth. You've got impacted wisdom teeth in 3 quadrants, root canal. You can see the pins everywhere that there's a blood vessel when the surgeon's in there. Clip, 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 clip. It stops the patient from bleeding out. Focus on the task at hand. But remember, These surgeons are in there anywhere between 10 to 20 hours in the operating room taking care of these patients. And that is physically amazing what they're able to accomplish in order to save a patient's life. Next slide, please. So that's the radiographic image. This is the clinical image. See, this is a clean patient. There's not a lot of plaque, but this is somebody who has a severely dry mouth, lots of heroics, lots of patching of teeth, follow-up. So these patients need to be on minimum every 4 months for hygiene appointments. But even then, the prognosis on these teeth is terrible. Next slide, please. Oh, wait, stay there. Sorry. So if you look at the slide, the picture on the bottom right, so where it's white, that's where the tongue has been removed. So if you look on the left side, so the patient's right, that's the actual remaining amount of tongue. So this is a forearm graft in there. And if you look at the ridge crest, so on the bottom front, you'll see the tissue's been sutured down. There's no way this patient can wear a partial denture. Everything's tethered. It is really, really difficult. Patient can't move their tongue to the roof of the mouth. They can't move a bolus of food backwards. Difficulty swallowing, aspiration risk, pneumonia risk, just so many issues here. Next slide, please. So I'm really happy to show you where's this patient right now. So teeth have been removed, implants have been placed. There's 6 implants in the mandible. You'll see longer ones in the posterior, working around the anatomy. You know, there's no ideal here, but you do the best you can in restoring these patients. Plates left in, if you don't need to take it out, leave it, because otherwise you've got compromised healing due to radiation. The blood vessels shrink dramatically and the healing process is quite compromised. You have risks of osteoradionecrosis. So we have to be very careful in our planning, implementation, utilization of hyperbaric oxygen therapy, usually a 20-10 series, so 20 before the surgery, 10 afterwards, to facilitate healing. Next slide, please. And this is a patient clinically, so you'll see the healing abutments of the 2 posterior implants, the suturing. You see the dentures on the right. We've put holes in the lower denture just to facilitate it as a surgical guide, so the oral surgeon can then start placing the implants in those sites, so then I can put the direction of force down the long axis through the bones so I can not compromise the healing of the bone long term and ensure longevity. And then I can use a fixed implant prosthesis that then does not press on the tissue, and the patient can function there. I have to use a complete upper denture, and I will drop and make the palate of that denture very thick so that the remaining tongue will be able to move some of the food backwards as well as affect the speech of the patient, so decrease the airway so that we can have better sounding words coming out of the patient's mouth, be more intelligible and understanding, which again is quality of life, which is hugely compromised in these patients. Next slide, please. So what do we do today? Let's look at a way to change our conversation. So what if? Next slide. So we have to act cohesively. We have to advocate. Every single one of us, and I challenge you, every single person here, we need to advocate the benefits of preventive programs such as vaccine protocols. Our goal, my personal goal, is to fund vaccine programs for every single patient who wants and needs one. We need to eliminate barriers to vaccine, cost, availability, and knowledge. So developing tools, making sure that we really understand that if this vaccine, let's say 3 doses for an adult at approximately $200 a dose, is understood, this is an incredible ROI, return on investment, for anyone involved in this protocol. And it has to be available, it has to be easy. You know, people are a little bit lazy, they got a lot on their plates, we're all very, very busy individuals, a lot of balls up in the air. Let's try to make this as simple as possible. Developing communication tools. We have to have clear and concise language. There has to be a common language between physicians, nurses, pharmacists, dentists, everybody on this team. We have to be clear in our conversation to our colleagues and to decision makers, and we have to facilitating dental rehabilitation in a local and timely manner. These patients should not be without teeth for 2 years, as most provincial programs will require them to be before they're cancer-free. We've got such a high suicide rate in these patients, and depression and anxiety. Think about where most of us on a good day are. Now add on that. We have to protect the vulnerable patients and ensure their care is supported not just short-term, but for life. We have to protect our vulnerable. And this is the disease and sequela. You have to treat people close to home by competent certified clinicians, and the financial support currently is not good. So in Alberta, dentists are recognized as vaccinators. We have to support and encourage that. This is not a perspective of going in on anyone else's territory, but we have to realize, 0.8% of school children in Ontario during COVID did not receive the vaccine. So let's help each other. It's not like this is a business opportunity. This is protecting the vulnerable patient populations. So in Canada, we have approved procedural codes for dentists nationwide, which now include, as January of 2023, and this is great because I get to tell it to this team first, that dentists will be able to code for vaccine consultation, vaccine script writing, and vaccine provision. Not every province or territory will choose to include these, but it's really important to understand the why. And we need to communicate this with our insurance providers. They need to understand if we prevent this disease from progressing proactively, preemptively, then we will have less costs afterwards. This is really important for us to all get on board. Next slide, please. So what if? Well, I want you to look me in the eyes right now. Pretend you're a patient and you're sitting in my chair. I'm going to say, so what if I was able to write you a prescription today for some medicine that would prevent you from getting cancer? Would you be interested? So what if I told you this prescription would prevent you from getting 6 different kinds of cancer? So I have a whole other extended spiel beyond that. But then I follow up with, can I write you a prescription today? And I'm going to send this over, and I will give it to you in writing. And I've already got pre-planned and it's pre-programmed into my computer program with my digital charts. But I'm also going to send over a physical copy with the patient to go to the pharmacy. And I'm also going to make sure that when the patient comes back for their next appointment, I'm going to follow up. So we know it sometimes takes more than 1 or 2 conversations with the patient, but I'm going to make sure I follow up. And I'm going to make sure the communication's there, the emphasis is there, and they understand the why. So what if? What if we all could have that conversation? Next slide, please. So thank you very much.
Thank you. Thank you, Dr. Zaytouni and Dr. Cable, for providing these very informative presentations. If the audience has any question, you can type them in the question box and send them in. I see that we already have quite a few questions that have come in, so I'll move on to the question and answer period, but you can still submit your questions while we're discussing. So the first question, are there strains of HPV that cause oropharynx or more generally head and neck throat cancer that are different from the strains that cause the cervical cancer? We're wondering how the current Gardasil vaccine prevents these, and if not, is there a vaccine development for strains that would cover the ones not currently covered? So I guess we're wondering how the vaccine currently covers or not the head and neck cancer strains.
So the strains that are involved with the oropharynx are especially HPV 16 and to some degree HPV 18. So the vaccine does cover that. Even the 4-valent and definitely the 9-valent covers the strains that are involved with oropharynx cancer.
Absolutely. Number 16 is the one that's bad, but I think the conversation needs to expand to, if we've got a 9-valent vaccine, we're not just focusing, again, think about it as a world conversation. We're not just focusing on one country, we're focusing on all countries. We're not focusing on just one HPV strain. We're focusing on as many as possible because although head and neck cancer may be the center of our world, patients have concerns with all different kinds of cancer. So The most up-to-date vaccine is the current one there, and then the question should progress to, well, what if I've had a series of 4-valent or 6-valent in the past? I do not have the up-to-date 9-valent, and that's where having a new series done for what's most appropriate for you.
Great, thank you. Next question, what would be the preferred intervention for a patient with an HPV positive neck node surgically removed, but no identifiable primary site on full examination for a male patient age 45?
So that's a good question. So when they are diagnosed with an HPV positive cancer, usually we try to avoid taking out one node. Try to find the source, because it's important to find the primary. And we use robotic surgery to do an operation to remove the tonsil on that side and part of the base of the tongue if we don't see the primary in the OR, and have that analyzed. Usually, in most cases with robotic surgery, the primary is very, very small in these what's called unknown primaries. So most of the cancers are not unknown primaries. You see the neck node, you examine the patient, and you take your time, and you'll find the primary. But in the small number of cases which are sort of unknown primaries, when you do the surgery, you find it. If you don't, then you would give radiation to that side of the tonsil, the oropharynx, a number of other sites, and the neck. We try to avoid taking out nodes, so we'd make the diagnosis based on fine needle biopsies to confirm that that neck node is cancerous or not. And if it is cancerous, then we make every effort in the clinic and ultimately in the OR to find the primary.
The great thing about head and neck tumor pathways across Canada, and I know that Dr. Zutuni is the lead of his, and I'm part of the one here in Alberta, is that there's a multidisciplinary investigation in the patient when they first are identified. Let's say they come in with a neck mass, and that's when you have PET scans done, you have all sorts of imaging and analysis before the surgery is actually done. And then the different specialists come together, like the radiation medical oncologist, to find the right approach for that specific patient. So it's not necessary to identify, for the general clinician where to find that primary mass at the time. It's just important to get them to the right person, like somebody like Dr. Zutuni.
Great, thank you. I just saw my dentist last week, and I was wondering, how do I know if the oral examination that was performed or not was optimal? What is the best way to ensure this was actually performed? I'm feeling maybe it was not done.
So I like to use really common language with my patients. Say, show me your uvula. Most people will be able to open up properly. Someone should be feeling bimanually on the floor of your mouth, doing a neck assessment, palpating. That's how you'll know it's optimal. If they're moving your tongue to the side, when they grab your tongue, you stick it out and they grab it with gauze, and they're looking at the base, that's what we're looking for. So if that wasn't done, you can request that. And if you're still not comfortable, maybe it's time to change clinicians.
Good, thank you. What is the risk of a client that has had genital warts in getting oral pharyngeal cancers if you are or aren't vaccinated?
Well, the way we realized that the HPV was associated with oropharynx cancer was we saw a higher incidence of oropharynx cancer in the husbands and partners of women who had cervical cancer. Warts are different, though. So I think the short answer is I think the risk is small. It's very, very small still, but you would want to get vaccinated to avoid that. I think that would be the key message. So it's not a situation where we need to panic, but it's a situation where you need to act, reasonably, responsibly. Get vaccinated, and the partners should also be vaccinated.
Thank you. Is there any tests for HPV? How would a patient know if they are carrying HPV before a cancer or warts are presenting?
So we're doing research on that, and the research is looking very, very positive. So right now the answer is no. Unlike pap smears, which you can use to diagnose pre-malignant conditions, there is no equivalent test in the oropharynx. So if you look at a tonsil of somebody who doesn't have cancer, it looks normal. If you do a swab of it, it's still normal. There's nothing like a pap smear. We are looking at circulating DNA. So cancer cells break down sometimes and the DNA comes out. It doesn't last very long in the bloodstream, only a few minutes, but if you take a blood test, you can see circulating DNA of many different types of tumors, including oropharynx cancers. So we and other centers, but we're one of the leaders in the world, have published some papers looking at ways of early diagnosis. So that somebody has an HPV cancer will be located by just a blood test. And we're also looking at similar tests using just saliva. We don't even have to do a blood test, just donate some saliva, and we can find the DNA that's specific to these tumors. So this is sort of on the cutting edge right now.
Great, it's exciting. When recommending the HPV vaccine to patients, what is the best approach for those who respond that they only have one sex partner and therefore don't need the vaccine?
I got the best response for that one. Nobody goes into a marriage expecting to get divorced. Everybody goes in expecting that things will last. This virus can stay in your body dormant, latent, for up to 30 years. Dr. Zaitoni was showing that in one of his slides. It can stay there until it's the perfect storm, and then something converts. When people say, I've been with my partner, things are stable, we've been together since we were high school sweethearts. Well, that's the ideal. I like to take a bit of a dirty, hairy approach as well and talk about insurance. You think about your children on the internet. You're pretty sure, things are okay, but you're not sure. You got that gut feeling where what sites are they on, depending on their age and confidence. And you put up blocks and you put up screens just in case. So let's have a conversation about the vaccine being an insurance provider. Let's think about this. How lucky do you feel? If this is a medicine that can help prevent cancer, and let's say, you have been with your partner for 20 years, congratulations, I'm really happy for you. But if you think, if you may have had something in the past or your partner had another partner previously, there are no guarantees in life. Let's just think of this as an insurance program to prevent things from getting worse, from any chance of this. Cervical cancer is devastating. It's horrible. Having someone like Michael Douglas coming forward at an event and looking at his life, he's an amazing spokesperson. These are people that patients will identify with and will be able to think about. But having the conversation about, how lucky to feel. I can give you this prescription today, and we can prevent cancers from happening. And if you are in that environment where the virus takes hold, it can be devastating for life, for the remainder of your life, not just for you, but for the people around you. So if someone's coming in and they're having these questions, say, I'm okay. It's like, okay, but plant the seed of the idea in them, and then follow up. And if they're not interested, hey, they're not interested. You don't have to save the entire world, but you have to start the conversation.
Thank you. I think that's a very important point. Unfortunately, this is all the time that we have for the Q&A. I know there were quite a bit that were unanswered, but as mentioned before, we'll try our best to answer them in writing. I would like to thank both our presenters once again for the excellent presentations and for taking the time to respond to the questions from our audience. It's been a pleasure working with you both on this educational webinar. We also, once again, very much appreciate the support of Merck Canada that allowed us to bring this webinar to you at no cost. Please remember to complete the evaluation by clicking on the link in the follow-up email that you'll receive shortly. Otherwise, you can also copy the link that you see on the current screen. A reminder that the webinar has been recorded and that the recording as well as the slide sets will be available on both HPV Global Action and CIDC's websites. There are also a number of resources on both websites. We thank you very much for your interest in the CIDC webinars. Please keep an eye out for the email notice regarding our upcoming webinars. Please enjoy the rest of your day. Goodbye.